Hi, and welcome to our live webcast from EMS Today. I'm A.J. Heitman. I'm the Editor-in-Chief of GEMS and the Conference Chair here at EMS Today. We thought it'd be a great opportunity for our audience here who's live, as well as for those of you who signed up for our webcast today, Disrupt the Odds, Enhancing Community Paramedicine and Response, sponsored by Boundtree Medical. Boundtree, as you know, provides products, services, and support to help you save minutes and save lives. With over 40 years of experience, Boundtree understands the EMS industry and is passionate about the communities you serve. And I underline the word communities because today's webcast is focused toward community support. And that's the specific goal here, and that's disrupting the odds. I'll explain that a little bit better, but first a couple housekeeping things. The presentation is both live and interactive, and you can ask questions at any time by typing them into Ask a Question box in the presentation window. Then just click Send. The questions will be answered during the Q&A portion at the end of the webcast. We have somebody who is prioritizing them like a triage officer, and a high priority, medium priority, etc. And if we merge a few together when I'm done, those will be eliminated because we've answered them for several people in one question. Those of you on site will have a microphone, and we'll alternate between the microphone and our online audience. If those of you at home are having any difficulties, please alert us through the Ask a Question box, and a member of our technical support team will be right there to help you. If you have multiple programs open, we recommend that you turn them off so that you're just dedicated to this. And if you have any kind of blocking programs, you should disable those. It includes streaming video. Once it appears and begins playing, you can enlarge the video player by clicking on the double arrows in the bottom right-hand corner, or you can leave it in the side-by-side mode with the slides to the right and the video to the left. Please make sure to close all those unnecessary programs. And our online audience, to get CE, must fill out the exit survey, very brief survey at the end, to receive their credit for today's program. So it's often said that the odds are stacked against us when we're called upon to respond to extremely time-sensitive events like cardiac arrest, severe hemorrhage, and overdose, particularly those that are not breathing. And saving lives under time-sensitive conditions now requires community involvement to really be successful prior to the arrival of emergency responders. You know, we forgot about the community. We forgot about a lot of things, and online programs and other things to alert us that our neighbor's not breathing is extremely important. So we've titled this broadcast, Disrupt the Odds, Enhancing Community Paramedicine and Response, because you and your agencies are finding important, unique ways to disrupt the odds of death and save the lives of patients with time-sensitive conditions. This broadcast is going to address three important areas that agencies can and should focus on with their communities about MCI active shooter events, sudden cardiac arrest, and overdose epidemic. So in the case of cardiac arrest, I might be preaching to the choir, but obviously, if defibrillated within the first minute of collapse, the victim chances for survival are close to 90%. I kind of like those odds. I wish my 401k would perform like that. For every minute, though, that's delayed, survival decreases by 7 to 10%. So if it's delayed by more than 10 minutes, the chance of survival in adults is less than 5%. That's not something that I want my relatives to have to face, so that's why this is pretty important. An active shooter and other incidents where a person's bleeding profusely, depending upon the area affected, we could potentially lose all of our blood in our body in 1 minute. The aorta, your main blood vessel, has just 5 liters of blood flowing through it every minute. That's really not a lot, and much of it can be lost if an artery is severed. So the use of tourniquets and other things in those first couple of minutes. And we know active shooter incidents are over statistically by the FBI within 5 minutes. That's time dependent. And over 42,000 Americans died of opioid overdoses in 2016, and government and public health officials have been scrambling to find effective ways to reverse this frightening trend. It's going to be a while till they reverse that trend, so we in our community are going to have to respond to it. I personally was involved in responding to one who was 80 years old with a lump of money in his pocket and not breathing, overdose victim. Sad. Agencies confronted with a significant incidents have had to get innovative in their response to and follow-up to overdoses. So today's presenters are explain how their agencies have partnered with other state and local services and systems to drive the implementation of cutting-edge, forward-thinking approaches to national problems within their community. Each of the agencies that I'm going to identified a need and worked to obtain the required funds and operational support, and as a result have been a significant force for positive change. So let's get right to it here. I'm going to tell you about each speaker. I'm going to tell you about their program, and then we're going to start with the first people that I'm talking about now, and they're going to come up and tell you about their program. So to my right, second from the right, is Dan Ellenberger, Director, University Hospitals EMS Training and Disaster Response Program. He's also an EMS 10 winner this year for this program that he's talking about, so it's timely that he's on the stage. With him is Dominic Silvestro, paramedic and EMS coordinator at University Hospitals EMS Training System. Dan's been director of the University Hospitals EMS and Training and Disaster Preparedness Institute for over 40 years in the fire and EMS industry, several years as a professional fire chief, flight medic, EMS educator. He's served multiple communities in the capacity of firefighter paramedic, as well as holding progressive, innovative leadership positions. But he currently oversees a wide range of pre-hospital and hospital entities. They serve, through his system, 180 fire and EMS departments under the University Hospitals medical direction. That's more than 100 staff paramedic educators. They also have disaster preparedness coordinators, EMS education, community outreach, nursing staff, and physician medical directors. So it's a very robust program. The influence and continuous collaboration of Dan leading his teams had led to significantly improved patient outcomes and innovative outside approaches. With him is Dominic Silvestro, who's been in fire and EMS for 30 years, served as a career firefighter for the Richmond Heights Fire Department in Richmond Heights, Ohio for the last 25 years, where he also, in addition to his firefighting, served as their department public education officer, a really important role in this community stuff. He's also EMS coordinator and EMS educator for University Hospitals EMS Training and Disaster Preparedness Institute. Now, the program that they're going to talk about is the University Hospitals EMS Training and Disaster Preparedness Program, far-reaching Stop the Bleed program, which has trained thousands of school staff and placed Stop the Bleed buckets in hundreds of Cleveland area classrooms. To their left is Maureen Mo O'Connor from the Public Access Defibrillation Program in San Diego Fire Rescue, San Diego Project Heartbeat. Mo O'Connor has been in the field of EMS for 25 years, serving the communities of San Diego County, first as a first responder in many facets, and then working on some of San Diego City's busiest paramedic units, and as an EMT for San Diego Fire Rescue. Served as a firefighter for the city of Poway, and worked as a ranger diver for the city of San Diego. Way to go, Mo. She currently serves as the PAD program manager for San Diego Project Heartbeat, one of this nation's first defibrillation programs to offer such a unique opportunity. Their internationally recognized program was named the Best Large Community Program of the Year in October of 2003 by the National Center for Early Defibrillation. It also received 2009's Heart Safe Community Award, PAD program, Large Community from the International Association of Fire Chiefs, and the Sudden Cardiac Arrest Association's 2009 Sudden Cardiac Arrest Association Public Service Award. Maureen and her team have helped bring the dream and foresight of public access defibrillation and early access defibrillation into fruition within the counties of San Diego County and all other communities, deploying nearly 9,000 AEDs, and the key result is 175 lives that have been saved so far. So I'm glad to live there. Then we have Billy Wisterhausen. He's the assistant fire chief, Round Rock, Texas Fire Department, and Dan Sledge, who is the Williamson County Mobile Outreach Team and one of their coordinators. Billy's been involved in the fire service since 1991, where he began as a volunteer and was hired in 1995 at the Round Rock, Texas Fire Department, promoted through the ranks, and currently serves as assistant fire chief. He's worked in every division, in every capacity, and is also a commissioned police officer. He also volunteers as a response coordinator for the Texas Line of Duty Death Program, which is significant. Forgot to show you Maureen's beautiful photo there. Yes, a forever picture. It's beautiful. Dan Sledge works as a community paramedic with the Williamson County Mobile Outreach Team, the initials MOT, and MOT responds to mental health crisis calls in the field. Dan also conducts follow-up visits, which is key to this program, for patients who receive DMS treatment for opioid overdose. During the follow-up visits, he provides Narcan kits, trains patients and their loved ones in its administration, and more importantly, helps connect them to treatment and resources. So the team has expanded its scope beyond mental health calls and now responds to opioid overdoses, not only to provide patients and their family with life-saving Narcan, but that very important longer-term treatment, and to offer it quickly even if the patient is uninsured. So with that, ladies and gentlemen, I am glad to bring up the Dan and Dominic show. Dan and Dominic, thank you. Thanks, guys. Dan.
Thank you. Hi there, I'm Dan Ellenberger from UH, and this is Dominic.
Hello.
And we're going to just sort of run through our program a little bit and explain to you a little bit about Northeast Ohio.
Give you a little idea of what our program is, how the program kind of started, snowballed, and grew, and then with the ultimate goal we'll talk about at the end of this of you taking this information out and hopefully starting this in your schools and businesses across the country.
So University Hospitals, we have 11 community or 10 community hospitals and a quaternary care center. We also have freestanding ERs in the community. We also have a level 1 trauma center with 4 level 3 trauma centers, so we're a true trauma system. We're responsible for 181 EMS services, so we don't run the services. We provide the medical direction and the oversight, the equipment, the education, the drugs, our protocols. We're also responsible for the disaster preparedness for our health system and also into the communities. We provide the event medicine in Northeast Ohio for university hospitals, including the Browns, which the Browns this year looked a little bit better. What do you think?
Come on, a
little help with the Browns. All right. And then we do a lot with also community outreach. I'm the director of community outreach for the East Region, and that's sort of where this program really came into event. We also manage 5 American Heart Association training programs. We have 5 paramedic programs, and our whole goal with university hospitals is building life-saving communities in Northeast Ohio.
So unfortunately, when you end up with a good program, a lot of times these things start from tragedy, and we were no exception to that. Chardon, Ohio is a rural community in Geauga County in Northeast Ohio, probably 25 miles from Cleveland. Kind of the heart of what you would hear the snow belt. Like other areas get 2 inches of snow, they get 3 feet of snow that same day. On February 27, 2012, students were in the school. The day was getting started, and there was a group of students in the cafeteria awaiting their bus to take them to their vocational education program. A 17-year-old male sitting with that group had a gym bag with him. He opened fire in that cafeteria, taking the life of 3 students, injuring 2, 1 critically, and that 1 student is permanently paralyzed. During that event, obviously, chaos broke out. This is a very quiet rural community where you wouldn't expect this to happen. I don't think we expect these to happen anywhere. As far as hitting us close to home, our sheriff deputies had students in that school, their children, as well as one of our medical directors, Dr. Garlisi. His child was in the school at the time. This kind of prompted a lot of discussion, and I'll let Dan go into a little bit of the discussion in relating to this shooting, and then obviously everybody wanted to know what could we do, how could we make this better. People felt handcuffed, they didn't have the equipment they needed, they didn't know how to go, a lot of the TEC stuff and that was coming out at this time, tourniquet use was coming back in, but we didn't have a formal way of training people to do this.
So we met with the Geauga County Sheriff, and we looked at what can we do to outfit the police cruisers, because as the police cruisers being the first responders, they really didn't have the equipment. So we developed a bleeding control kit, a lot of what you see now on the floor in the trade show today, but we actually put a program together that was for the police officers and also acts of violence. So if they came came upon a shooting where they needed a chest seal, a needle decompression, combat gauze, tourniquets. It was all placed, and we placed these in the driver's compartment of the sheriff's cruisers. And with that, we deployed AEDs. So that was part of our first blush on getting out into the communities and to provide bleeding control. And then, so we trained up all of the police officers in Geauga County. And that's sort of where this whole piece sparked. We also provided about 25,000 people last year in CPR with our training programs. We train most of the school systems. We train the seniors in high school, in the high schools. We also started training the teachers, and that's sort of how we have evolved.
So with our main campus hospital becoming a level 1 trauma center, we heard word of the Stop the Bleed program through the Department of Defense, and we jumped through some things and filed the proper paperwork and became a Stop the Bleed training center through the Department of Defense. Now we wanted to try to expand this through our community. So one of our first challenges was to develop a program to enhance community preparedness, as AJ asked us to talk about. And as the snowball started to grow, we were teaching sheriff's departments, local police departments, started expanding into other businesses and things, and then somebody came up with the idea of schools. And then you do this in one school, and then they tell 2 friends, and they tell 2 friends. But the goal was to train teachers and staff on how to stop bleeding, because we know, especially from Boston, that, tourniquets can save lives. And if we can stop the bleeding and keep the blood in the patient, we can do that. So having a program that we could teach teachers to do this, and then creating a kit that would allow everything to be in place, but not only for bleeding control, but we see a lot of shelter in place in these events, where they're stuck in the classrooms, or somebody was talking to me yesterday about their school district went on lockdown because there was a rumor of somebody in the neighborhood with a gun. And those kids were in that classroom on lockdown for 5 hours. So we tried to create a self-contained kit that would take care of this problem.
So we came up with a bleeding control bucket, and like every program, we steal things from each other. And one of the schools actually had a bucket, and his name was Tony Markajon. He was a assistant principal in one of our schools, and he had a go bucket, but it was all about radiation safety. Perry Nuclear Power Plant is near their school, and they had to have a shelter plan. And so we took the bucket. And the reason we decided to use a bucket rather than anything else, if anybody's ever been to my office, they see my desk, I have piles of paper. And when the piles of paper get so high, they go on the floor. But the same thing happens in a classroom, is that when we looked at trying to put a first aid kit or a bleeding control kit, it would just be tucked away. A 5-gallon bucket's a little hard to just hide in a corner or whatever. So we looked at that for a couple of different reasons. One is putting an emergency kit in the classrooms, something that they could see, and actually to have the teachers embrace, and the buckets actually became the teacher's device. And what we found is that with meeting with the superintendents and building this program, that we were able to get the teachers to buy in, and that in every classroom, these buckets are the teacher's device, and they're for their classroom. So they actually shepherd this program. And then just when you look at it, we have the bucket, but we have bleeding controls, we have duct tape. We put duct tape in there, one for sheltering, one for being able to close off the windows so that a perpetrator cannot see into the classrooms, door wedges to keep the doors closed. We worked with safety forces. And all of our programs are built in building life-saving communities with fire, EMS, and police. So we have resource officers in the school. They're involved. The local first responders are involved. And when we provide the training, and when we come in to train, we train all of the teachers at one time. We can train about 150 teachers in one classroom, or in a class setting, in about an hour and a half. But we do that with police. We do that with fire, EMS, the resource officers, because we want everybody to have the glue. And with a lot of the parents that were really pushing out that they wanted a plan, that it's come together. And so, our superintendents have been engaged.
And we tried to make this a kit that could sustain them for a while. I think people look at the kit or see the list and are like, what's toilet paper for? Well, if you're going to be locked down with a bunch of 7-year-olds in a classroom for a while, this bucket can double as whatever it needs to double as, and we've got toilet paper in there too to help them out.
That's why we called it the Go Bucket.
These are some pictures of our current storage situation. AJ mentioned a truckload. We have deployed thousands of these buckets. We'll show you in a little bit and talk a little bit about the cost and that. There are some people in here that are part of our EMS staff, and they're cringing right now when they see these pictures because these buckets are filled individually by our staff. They just line them up, and it's an assembly line. When we know we're going to a certain school system and we need 200 of them, we line them up and we go. So I'm sure you're thinking, what's the cost, right?
So our cost right now is between $300,000 and $400,000. Since this slide, we've deployed more. Each bucket costs around $70. We have a lot of different vendors wanting to help us package our buckets to drive the cost down, and so we constantly look at that. But the average bucket that we have is about $70. How we decided what to put in there was, again, we used the resource officers, we used the superintendents, we used the teachers, and that's sort of how the program. We actually talked to the kids. We first started putting candy. We had candy, and we found out the kids like Skittles. So we put Skittles in all the buckets. And one of the elementary schools, they nuked all of the Skittles out of the buckets within 1 week. The kids had broken into the buckets, stolen all the candy. It was gone. So now we're into glucose. We're putting glucose tablets in instead. But we actually, the money that comes back, how UH has funded this whole program. And we fund it under our community benefit. So some of you folks might be familiar with health departments and community health needs assessments. All the hospitals that are nonprofit, they have to invest back into the communities. Our leadership, I'm very fortunate to work for the presidents, and they believe in the community. We're community hospitals that are community-based, community faith, and they've written this into the community health needs assessment plans, and they fund it. And so that's sort of how we were able to get started. And we'll talk a little bit about ways that maybe you can take this into your communities.
So just the numbers, as you can see on the slide here, is that we've trained teachers. In-service days are a great way to do this because they have to be there. And like I said, we take about an hour of their time. But we've trained the teachers on in-service days. We've done over 100 school districts across our 22 counties. We've placed buckets in each of those classrooms. These are just some pictures of a recent event where buckets were presented. So far, a little over 4,000 teachers and staff trained, and we're guessing right now we're around 3,000 buckets out there, but we already have a few classes lined up coming up here through the end of the school year in summer, and we'll be right around 4,000 buckets deployed within the next couple of months. So the other question that AJ had asked us to answer was, what steps could you take to do this in your community? You're looking at those numbers of 300,000, and we are a big health system, but this might be your community, and you have one elementary school, or you have an elementary school and a middle school. So, how can you do this? And it's our hope that you would take this idea. We have a bucket up here at the end if you'd like to take a look at it or talk to us about any of that. We'd be glad to work with you.
So some of the things is, number one is, how many of you folks are Stop the Bleed instructors in here?
Good.
Okay.
Great.
Pretty easy to get to, right? It's not very hard. So that's one of the pieces to look at, is getting your agencies involved in becoming Stop the Bleed instructors. The other one is to network. School systems are funded on what? Tax levies, right? So, and if you think about it, in your jurisdictions, in your school systems, a lot of those teachers work in your community or live in your communities, right? And they're voters, and you're on tax supported. So again, bringing the community together on a common goal on how to educate just makes a lot of sense. So you becoming Stop the Bleed instructors, engaging the school systems. The superintendent has to be on board because he's the one who's going to, there's union contracts with the teachers, there's carve out time, but they can always, if they want to do it, they're going to figure out how they're able to get it done. And again, it's that program that's going to work. One of our deal breakers is that we train everybody in the school system, classified and non-classified. We want the bus drivers trained. We want everybody trained, and we'll provide everything to them free. It takes the fight out of you when you say, how much is a bucket? It's free. But there is a catch. The catch is that the school system is going back, and they're actually providing, they're providing the dollars for the education or the time allocated for the education. There's a lot of CPR programs that hopefully you folks are doing out there in the community. That's another time to tie in your Stop the Bleed programs. And that's really where we're at with the schools, is we train the teachers in Heart Saver AED, and then we do the Stop the Bleed right with them.
And then the other thing being, part of the initial cost, people see all the fancy simulation mannequins and things like that. We started this program using swim noodles and cutting wounds into them, and they could practice putting tourniquets on or packing a wound with swim noodles. So you can do this in a cost-effective way. Other ways that we would suggest you can go out there and get money to do this, again, remember your hospitals. A lot of EMS agencies don't realize that hospitals have this money already earmarked for community benefit, and it's pretty easy to get your hands on it. If you're a small district and you have a elementary school with 15 classrooms at $70 a bucket, you're looking at about $1,000 to put this thing together. Don't forget that there's scouting groups, guys, scouts that are looking for an Eagle Scout project. This would be a great thing to get off the ground with that. Your big box retail stores may help in donations of buckets and duct tape and things like that. Kiwanis, Eagles, all these organizations that routinely give money away. Get into your parent-teacher groups, PTAs and things, and explain to them the importance of bleeding control and how you can't just wait for the EMS agency to arrive. Your patient's going to bleed to death. You need to be able to put that tourniquet on or pack that wound. So hopefully we can help you get your program off the ground. If you have any questions for us, feel free to ask us after the event. The bucket's here if you want to take a look.
So trauma centers are government, they're evaluated by the ACS, the American College of Surgeons. One of the things that the ACS wants to see is the fabric of how the trauma centers are embedded in the communities. And so if you have the level 3s, you have the level 1s, the level 2 trauma centers in your community, I suggest you engage with them. You have the STEMI centers and the chest pain accredited hospitals now. They need EMS. So in the UH philosophy, EMS is our front door. EMS is our providers. Actually, when you look at our protocols, ABCD is done. Pre-hospital, before they ever get to the hospital, that work's done. And so the more you can build a relationship with your healthcare systems, the more that they'll help you fund your different programs.
And with that, we're going to turn the podium over to Mo with her program.
Good afternoon. My name is Maureen O'Connor, and I do go by Mo. I want to thank Boundtree and GEMS, thank you, AJ, for having me come and speak about the program that I'm so lucky to be a part of and program manager for San Diego Project Heartbeat. I'm hoping that from this presentation today you might get inspired or get some ideas of how we might be able to help your community. Our mission for the program, San Diego Project Heartbeat, was basically to make AEDs as accessible as fire extinguishers, but equally important is to educate society from very young to very old on simple recognition and response to cardiac arrest. When we started our program back in 2001, what came together, I like to say, is all the stars lined up just perfectly in our community. AEDs were a new thing, and public access defibrillation programs were new to our communities. A lot of people were really frightful about these things. So when we first came together, we got together with different coalition members in our fire and EMS department, and we, as a team, as a coalition team, looked at the things we needed to provide to the community to help them implement these programs easily and successfully with AED devices, training, documentation tools for maintenance and quality assurance. The coalition members that came together at first was basically our EMS department for San Diego Fire Rescue. We had an EMS chief at that time who was quite an entrepreneur, as well as a medical director who was very passionate about these new programs and really felt that these could work. They started to reach out to other members of leadership in the community, our fire chief, council members, and the airport actually at that time was interested in implementing one of these life-saving programs because they had heard of the success that Chicago O'Hare had. So our EMS chief said, sure, we'll implement a program for you, but at the same time, why not get a program going for all of our city departments too, and let's see how this works. Our county board of supervisors also caught wind at that time and said, well, we want to put this into our government buildings as well. And then our EMS chief, that guy who is quite an entrepreneur, said, well, let's not just do this for government buildings. Let's create a program where any public or private venue throughout the county of San Diego can implement one of these life-saving programs easily and successfully. Let's put something together to figure out how we're going to do that. Our other coalition members, looking into the American Heart Association, American Red Cross, their standards and guidelines. We also involved other like-minded entities, other foundations that could jump on board to help us get this program rolling. Political influence was huge as well. We had a council member who, in the very first month of his tenure, he had an 8-year tenure as a council member with the city of San Diego, took this under his wing and just championed this program throughout the 8 years, ending his tenure after working together for 3 years on the first ever municipal code that mandated AEDs in all new construction in the city of San Diego. That was back in 2008. And interestingly enough, one of his co-council members at that time, who became a senator, Hueso, in the state of California, ended up implementing this municipal code into a California state law. So it's pretty cool how this all came together, and it just kept growing and growing. Mission advocates are very important to involve in your program as well. We had a very well-known community member who lost her husband. She actually was running for city council at the time, right before we started this program, and she and her husband, who were well-known in the community, her husband died from cardiac arrest at a 10K run, very popular 10K run he put together in San Diego County. And so people who have lost loved ones, and now we're gaining so many more survivors of cardiac arrest, can really speak to this program to the community. They add that personal touch to it. In looking for AED devices, at the time when we started the program, there were only 3 manufacturers who were FDA approved. So since that time, I understand there is somewhere close to 40 AED manufacturers nowadays. Every 5 years, because I work underneath the municipality, we look for high-end quality AEDs for our program. And when I say high-end quality, I mean a company who has had longevity in creating cardiologic defibrillation technology. And nowadays you can find several high-end quality manufacturers that have had success in other major municipalities or large institutions. Certification training, we set up an American Heart Association training center. When we first started this program, it was unbelievable. You had to be certified in order to utilize an AED, and also the law required that you be refreshed in that certification of how to use the AED every 3 months, which is, as we all know, is just, it's so silly. And I'm so glad that the laws have really loosened up to keep it simple for all people to use AEDs. So we're an American Heart Association training center, which provides the different disciplines of certification training to all county members throughout San Diego County. That's part of the sustenance of our program. We also provide maintenance and documentation on maintenance compliance for the AEDs. Most states require some type of documentation maintenance for the AEDs that you have within your program to make sure that they're ready to use. And also for QA, medical direction in the state of California was a requirement up until 2016, but we have maintained medical direction because I see and we see the value of having a medical director who is involved in the program, can add initiative, and then our medical directors for the program, they review all of our deployment cases, and they can also pinpoint if they have concerns in certain deployments, certain scenarios that happen, making sure that the AED is defibrillating correctly. Over the 18 years of the program, not too many of those cases, but there has been a few where we've addressed AED manufacturers in that regard. You need to educate your EMS teams out there. You need to let fire and EMS know about these AED locations and set up protocols where there can be good communication between your program and the crews that work out there in the field. There's many different aspects of that, including dispatch. We have several different ways that we are notified immediately of a cardiac arrest incident where an AED was used, because part of our maintenance includes incident maintenance, where we respond to any deployments that happen among our program participants. So our program basically offers a high-end quality AED package at a reduced price. We have, as I mentioned earlier, we go out to bid every 5 years to look at the latest in technology. We're always able to do that a little sooner if we're not happy with the current manufacturer that we're working with. The City of San Diego also has this really special program called the Corporate Partnership Program, which I'd be happy to discuss with any of you after this presentation, which I have found it to be a real win-win-win for everybody in the community for that program, where we work with finding an AED manufacturer and through our RFP system. I mentioned we're an American Heart Association training center, also providing program and incident management services. Those incident management services are really special in our community. In the County of San Diego, we have 4 full-time uniformed staff members who are on call for our program 24 hours, 7 days a week to respond to any deployment that may have occurred through any of our program participants. Each of our deployment team members are well certified in advanced critical incident stress management. So when we go to scene, we gather the information to collect information to do reports. We put their AED back into service, download that EKG information, and then we also look and identify perhaps any need for critical incident defusing, not so much debriefing, because what we're really interested in is helping to normalize the event for the average public in society who is involved in this event. I have found that service to be incredibly beneficial. We've gotten a lot of good feedback on that. After we're done putting that program back into service that just used their AED, then we're able to take that vital EKG information directly over to the hospital that we have seen actually change the therapy for that cardiac arrest victim in the hospital moving forward in their treatment. It's really cool. One of my favorite things to do, and we're really expanding on in our program, is our free hands-only CPR AED training, hands-on training. We provide this to all our program participants. Providing trainings I can usually do by myself between 12 to 50 people at a time. We have hands-only mannequins that we take out there and give people an opportunity to actually get a couple of minutes of hands-on training. I am finding that hands-on training is a great benefit, not only in educating these folks, but in getting the word out there about the program and helping people feel comfortable about this. We've had such super success with San Diego Project Heartbeat. As AJ mentioned, we've helped to deploy over 9,000 AEDs, and since I last sent my slides to you, AJ, we've actually saved another life. 176 lives saved to date just through our program participants that we manage throughout the county. 3 of those were children. I'm telling you, when you can go into schools and educate people on the Stop the Bleed kits and other things, when you can educate those PTAs and parents that, hey, has your kid had a cardiological workup? They're pretty amazed to find out that there's about 10,000 children every year in our nation that die from cardiac arrest, but fortunately, we are saving them too. 3 lives out of these 176 were kids, all 3 at school. All 3 were docile. They were not involved in any athletic activity, but they're here today because their school had an AED program in place. And many, in fact, most of our life survivors, most of them just got hands-only CPR. It's a cool thing. We have been nationally and internationally recognized. I'm very proud of the program. And I know personally, according to my calendar and what I calculate every year that I report to my leadership, I know that I'm involved in training about 5,000 to 6,000 people annually just in hands-only CPR, and it's important that you get their hands on and keep it simple for them. Which comes to this slide. My favorite mantra for teaching, keep it simple for the student. When you can get out into society and educate the general public who aren't people like us, medically trained rescuers, on just simple things to remember. Less is better. They're apt to remember it more, and they're also more inspired and confident in actually doing something. I was at a conference about a year and a half ago, a cardiac conference, and I found it very interesting, and I enjoyed how you said that. We steal things from each other when we hear these things. Sometimes it clicks and it goes, oh, I'm going to use that. This no-no-go concept that I'm speaking of here in training hands only, they were using this concept at a conference to actually educate dispatchers throughout the globe on how to best identify a cardiac arrest with a panicked 911 caller, to get these questions answered. No response, no breathing, go. Start pumping hard and fast. And I went, no, go. I like to use music and stuff when I teach. I like to really involve the audience. So I teach them, no, go. No response, no breathing, go. Call 911, get an AED, come back and start pumping hard and fast. I also teach at least 100 beats per minute. I know our standard is 100 to 120 beats per minute, but the less is better, I find. If you throw too many numbers out at people, they get confused, and then they get scared and apt not to put their hands on somebody because they can't remember which number they're supposed to remember, as well as the depth. If you get 1/3 depth of chest on all people, infant, child, Charger linebacker, anyway, no, I'm just kidding. Sorry, long time San Diegan. 1/3 depth of chest is a great way for people to remember. So at least 100 beats per minute, 1/3 depth of chest, and you got to give them at least 2 minutes if you can on that mannequin. I know I'm talking a lot about this bystander CPR training, but one of our former medical directors who actually helped start this program, before he retired, he put together a PowerPoint for our EMS department which showed our statistics basically for the CARES program, which we had been involved in for quite some time. And everyone in our department was so amazed at our statistics in bystander CPR, which I have to really attribute to getting out there and educating society as a whole. We had, a little bit of just common ground for quite some time, but I found it interesting in 2016 how we jumped up 14% in bystander CPR being performed. It was about January of 2016 when the law finally excluded certification training out of AED programs in the state of California, and we started training more people in just the simplicity of quick recognition and quick response. And so these programs really do work. Again, my name's Maureen O'Connor. My contact information is here for you. Please let me know how I can be of best service to your community. We've helped a little over 50 major municipalities, even the state of Nevada, to implement a program like this. So please let me know how we can help. And again, I want to thank you both for inviting me to share the passion of this program. And now I'm going to turn it over to Billy and Daniel.
Hello, I'm Billy Wusterhausen. I'm an assistant fire chief for Round Rock Fire Department. It's a little town just north of Austin, Texas. Our department provides, the basic fire services and a basic medical response, but EMS through the county provides our EMS transport. And the title of today's class, Disrupt the Odds, is such a great title for all of these programs. And, you can go back to the fire station or the EMS station and ask, if you were to get a call today, where would it be or who would it be for? And most of the staff can tell you, it's going to be at such and such address. He's been calling a lot lately because of this condition or that condition. And so when you look at how we respond to things, our system is really designed to just respond to a symptom, mitigate that emergency, and treat that. But it doesn't really dig into the problem and what is actually causing that person to rely on the 911 service. So, your traditional response then to our 911 system is you call 911, you get police, fire, EMS, and then the outcomes, either they go to jail, they go to the hospital, or it's resolved there on site and nothing happens. But if we continue to just treat the symptom or the problem or and not dig deep into what's causing it, then we're going to end up having the same caller call back. And so we all know who those are. We even title them as frequent flyers or loyal customers. I don't know of anybody doing like a 9 trips to the hospital, you get to 10th trip free program yet, but that's probably down the road, right? This became kind of obvious to us in a number of different facets, and we have what we call a community risk reduction program to try to deal with those. But particularly with our EMS patients, we have a patient that we responded to for a CPR call. I didn't find out about it until we were doing the awards and found a CPR save for the same address. I had 2 awards come across the desk, and I thought maybe it was a duplicate entry with the wrong date or something, and it was actually the same patient that had overdosed 1 week apart from the previous overdose. So, the residents there called 911. Our fire, police, and EMS units responded out. They resuscitated him, transported him to the hospital, and 1 week later to the day, they're responding back out there for an overdose, and again resuscitated him, and he lived. We got 2 cardiac saves out of that. So it really started us thinking, that while we don't have a whole lot of overdoses in our area, we've all heard of the national opioid epidemic, and it's like, this falls into our community risk reduction program. And there's, if there's anybody that can do something about it, it would be us then. And so we've partnered with other organizations to try to make this, to actually get to the root of the problem and then to bring solutions to it. So our community risk reduction approach is to mitigate that immediate issue that is presented there for you, and then referrals as appropriate to the right resources. So as I was saying earlier, not everybody needs to go to the hospital or go to the jail. Oftentimes they need to go to some outpatient services and so forth. Follow-up appointments are very key to this as well, to keep them on track, and then trying to get them lined up with long-term resources. We've got to interrupt that continued reliance on that 911 service, and the only way to do that is to sit down and have those frank conversations with them and find out what the underlying problems are and be able to address that. So some of our partnerships was with the state in order to obtain some funding to be able to fund the program, and then also since Williamson County EMS had a mobile outreach team that's already been doing great things and been recognized nationally, we wanted to partner with them to take on this opioid response as well. So I've got with me Daniel, who's one of our practitioners, and I want y'all to just listen to him and kind of his passion and what the program is able to do and has been set up for.
Thanks, Steve. Hi, my name is Daniel Sledge. I'm a paramedic for the Williamson County Mobile Outreach Team. I'm also a person in long-term recovery, and I'm grateful to be here and to be in the role that I'm at Mobile Outreach Team and be of service to others and carry the message of hope and recovery. We, as Billy mentioned, we're under EMS and the emergency services. We're a small but mighty team. We've got a director and administrator, 6 mental health specialists that are either licensed professional counselors or social workers, and we've got 3 medics on our team. We respond to emergency behavioral health calls through the 911 system is how we're dispatched. We collaborate with law enforcement and EMS on scene to come up with the most appropriate care plan for the patient, whether it's helping them purchase a medication refill from Walmart using flex funds, or it could be facilitating and transporting to an inpatient hospitalization, just depending on the needs. A lot of these calls will end up being emergency department or jail diversions. That's another way that we're able to show return on investment. We also link patients to detox and facilitate treatment at residential treatment facilities. In late 2015, the governor of Texas signed into law Texas Senate Bill 1462, which expands the access to Naloxone. And the next year, MOT partnered with an organization called the Texas Overdose Naloxone Initiative. and they donated to us some naloxone. And what we did is tried to brainstorm ways that we could target it best at the folks who are in most need of it. And so we began running reports and queries on our charting software, where the easiest way to do it was to run a query on naloxone administrations. And so you go in and you read the narrative, and not every naloxone administration is an overdose. It could be in a CPR call, or it could be in a coma with respiratory depression of unknown origin. So kind of weeding these things out, and then go and doing follow-up outreach, or these post-overdose door knocks is kind of what we do. So here we are. So like everywhere in the nation, we've got an opioid overdose issue. We don't have the most of the U.S. or anything like that, but they are occurring with increasing frequency. Our issues in Texas are more revolving around capacity and access to treatment. We're next to last in access to mental health care, and in access to substance use disorder treatment, we're dead last. 2 weeks is the average wait to get into state-funded detox, although I think that number's kind of generous. And up to a month is the average wait to get into state-funded residential treatment. A lot of times when we encounter patients who are in a window of being ready to initiate recovery, the window doesn't stay open very long at all. We want to engage these people right then in that moment to initiate treatment. So that's where the HHS grant money came through, is to fund these gaps in care that exist. So the model is to engage patients in outreach and start this gap coverage care while they're waitlisted for state-funded treatment. And we partnered with our, we've got a ferocious medical director at the health department who's a big champion and advocate for public health. And this crisis has been called a public health emergency. And so she's on fire to treat folks, especially folks who can't otherwise access treatment. And so she got her X waiver to be able to prescribe buprenorphine. And we'll get patients in to see her, and she treats them while they're on the wait list for the state-funded treatment. And the state-funded place, the office-based opioid treatment, loves that, because when they receive a patient from her, they're receiving a stable patient who's already on a dose, and all they have to do is take that patient and then continue current therapy. So another piece of the grant was Narcan distribution. We've done over 60 trainings for different community agencies, whether it's schools. We've done trainings for law enforcement, recovery housing, residential treatment centers as well. We've distributed over 11,500 doses. A lot of those doses went to our partner agency, the Texas Overdose Naloxone Initiative, who then got them to organizations that they've previously trained and now can get the medication. Most importantly, though, is the medication that we distribute to overdose survivors and their loved ones, people who use drugs, their roommates, people who might witness or encounter an overdose, so-called non-traditional first responders. So some things that you might be able to employ are to, number one, identify these patients, and if you've got a CHP program, do some outreach. There's different ways to ID these patients. You can do kind of what we did and run a report, different queries on your EMR. If you've got folks at the EMR company, they can add a checkbox or something that then alerts the CHP team automatically. You can get a radio alert from crews. and also just have people email you a run form, or a run number rather, different ways. Engage folks. So when we do outreach, we're there and we say we're not here to shove treatment down your throat or anything like that. We're on your team, and we use the principles of motivational interviewing to help them be a patient-centered goal setting and figure out how we as a team can meet those goals. Make friends with your community agencies. Make partners with agencies such as harm reduction coalitions, syringe service providers, recovery-oriented systems of care. There's prevention coalitions and peer recovery support services, which is very important. To have somebody sit knee to knee with a patient and say, I want to tell you my story of experience, strength, and hope, and provide that. And then a lot of these places are doing naloxone distribution already, and so saying, you know what, let's start an MOU or a partnership. Come do outreach with us, help us build these bonds and trust, and we can access these patients and get them into treatment. Medication-assisted treatment is the gold standard. Medications like buprenorphine, methadone, and extended-release injectable naltrexone. We need to build low-barrier access to these medications. They're evidence-based, and they show a 50% reduction in all-cause mortality and over a 70% reduction in overdose. And there are very few things in medicine that have a mortality benefit such as that. And I just want to end with, the first two patients that we enrolled with this program. The gentleman overdosed 2 mornings in a row, and on the second day we were out there, we brought the doc with us, and we screened these folks. She saw him the next day in the clinic and started them on medications. And it was the gentleman and his girlfriend. And they kept saying to us, thank you for not judging us. Thank you for not treating us like crap. You saved our lives. And though it doesn't look the same way as maybe a Phoenix Award or a CPR save, it's still improving and saving lives, which is what we're in EMS and what we're in medicine to do. And they recently celebrated 9 months in recovery, so that's what it's all about. Thank you.
Thank you. If our live audience has any questions, you can line up at the microphone. I'm going to start with one from online, and the very first one actually came from a hospital system, and people at that hospital system that were watching want to congratulate Daniel on his recovery. They're very proud of you, so congratulations. We have a question from Belfast, Maine about whether having a program like this and giving Narcan out widely and freely creates more usage of opiates because of an idea of a safety net.
Sure. Check. Yeah, that's a good question. There was a paper that came out about whether there's a moral hazard, such as does having an airbag in your car make you drive more recklessly, or a fire extinguisher in your home make you more arsonist. I don't really know, but no, there are no data to support that, and the same with having an AED or a fire extinguisher or anything else. We want this medication any and everywhere. People are going to use drugs whether or not there's Narcan available, and so what we want to do is just make this as accessible as possible, because dead people can't recover.
Okay. I have a question from Jerome, who's a 911 dispatcher, so this will go to Mo. And that question is, as a dispatcher and EMD instructor, I find at our agency most callers do not want to perform CPR. Any ideas on breaking that trend?
I like the no-go concept. I mean, educating them that it's very simple to pump on the chest, and it's really the only chance that person has to survive. So giving simple instruction, less is better.
What's your experience been in San Diego? Do you really get them on the phone, and do you find that you can make them do CPR now that it's hands only?
Yeah, I think really getting out in the community and educating the community, giving them a chance to get hands-on. They see how simple it is, how simple AEDs are, and that they can do something about it. Yeah, just simple instruction, simplicity is best.
Yeah, and my advice really to the questioner on the web is really emphasize that it's hands only. Around the country, when I go around, it's really increased because people were always afraid to do mouth-to-mouth, and they're not afraid now to push on the chest. So it's re-educating your dispatchers as well. Question, could you identify yourself and come with your question?
Testing. Oh, okay. My name is Thomas Levy. I am a paramedic and FTO with Western Carteret Fire EMS. My question to this panel is, besides finance, is there any hurdles that you had to go through or any roadblocks that you would say was probably the biggest thing that you had to, I guess, negotiate or navigate through?
Go ahead.
Hi, Mo. I think taking away the fear of responding, in the respect of like simple hands-only CPR. Also, the simplicity of the kits with Stop the Bleed. I mean, really engaging people, taking away that fear. Taking away that fear, I think, is the biggest thing for people. And if you can educate them and, get in their face,
is this
hands-on.
the fear from the administrators? Like, for example, for the Stop the Bleed, the administrators from the schools system or teachers, or what would you, or the community at large?
That was one of our things, too, when you had teachers that, well, I'm not a nurse, I'm not a doctor, and I know tourniquets are bad, because all of us remember tourniquets were bad for 30 years, right? And just trying to explain them to that and to get them to accept that they would do that. But showing them the data and the time of, needed to save a life before somebody bleeds to death generally hits home. That was one of our hurdles, getting people to do it.
The other piece that we really tried to drive home is Stop the Bleed is about the act of violence, but it's also the weekend warrior. Think about the people with chainsaws, circular saws, the things at home, kids that fall, even in the schools, kids that put their arms through windows and things like that. So we had some education hurdles, but everybody really jumped on, and actually the teachers and the superintendents really they've enjoyed it, and we always try to give that little bit for at home. Whether you like your wife or not, if she's in cardiac arrest, you're probably going to do CPR on her. We joke about it a little bit, but if AJ drops right now, we know that somebody's going to press on his chest. I don't know if anybody's going to do ventilations, but we know that we can convince anybody to do chest compressions, right? But it's really it's sort of a little bit of you joke with folks a little bit, but I think you can get everybody on board. And a lot of it is building the team and listening. You have to listen. People have fears, and then you have to dispel the fears a little bit.
And
one of the things that I'm also concerned about too with these programs, nothing wrong with these programs because they're really great, is the fear from administration as far as liability. That's the biggest thing they always talk about. Oh, if we do this, are we liable?
I think you're more liable if you don't do it. In today's culture and emergency care and this experience that we have in schools and active shooter incidents, schools that know that we're not going to be able to get to their kids for at least 5 minutes and their kids can bleed to death, I think are going to have some responsibility. If you haven't shared with people the Harvard Consensus, this is a federal document that recommends that this happen. I think the police departments are negligent if they're not giving tourniquets to their police officers, because it's recommended in the Harvard Consensus. So I would turn that around. I wouldn't even worry about that. I know of no situation where people have been sued.
No, I don't think at all. I think the other piece is that every school has to have an incident action safety plan. So this has to fit into it. Schools are being driven by legislation to be able to have to be able to have a plan in place, whether they're barricading, whether they're putting devices on the doors to lock the doors down. There's superintendents are being forced, and they're being also forced by the parents. We had a very, one of the folks that was very involved from the community, she drove the superintendent crazy on getting this program together. She was just that heartbeat that would not stop until she finally was able to, her voice was heard. She rallied the parents together. And, I think the risk for the superintendent was if he didn't do it, he wouldn't be the superintendent any longer because she was going to figure a way to get him out.
All right. So, thank you very much.
Yippee, you're welcome. I will just say here that we have Laura online who had asked whether there's any way to get a loaded bucket donated to their agency to be able to show to the people that they want to start and get a program started in Oklahoma.
Sure, email us and we'll send you one. Amy loves to send things out. She's a shipper.
And this is from A.J. Heitman. Can you send all of the Skittles that you offloaded from the kids to my address?
We'll ship.
What's a good, we have another person here from Norfolk Ambulance Service. What's a good ratio you would recommend for students to tourniquet ratio for buckets?
We do 8 to 1 or 10 to 1. 10 to 1 max. We use round tables. One bleeding control kit. We actually have now purchased all commercial bleeding control kits, but we like one provider with 8 to 10 being the max students that we have, because teachers are no different than firefighters or anybody else. We all have ADD, right? So if you don't have them engaged, they're gone or they're on their devices. So it's about hands-on, and they apply tourniquets to themselves. They apply tourniquets to each other. We do packing of the wounds. And there's actually some talk, there's question and answer, especially when we have our emergency providers there. They're able to talk about bleeding control and then what if and different situations. So really, I would max it at 10.
For San Diego Heartbeat, there are many programs that are now merging the Stop the Bleed with their AED programs.
Yes,
Can you address that?
San Diego International Airport is one of them. They've fit bleeding kits into their where their AED wall mounts are. And several of our program participants are interested in that. They're also introduced to it. Our core mission is still staying with cardiac arrest, but we're happy to help our program participants and beyond implement these important programs.
Yeah, and I fly out of San Diego Airport, and every time I walk past and I see they also have a bag mask in there, I really smile.
Yeah.
And you think, was somebody going to pilfer that? Well, they all have lights and alarms on them, so they haven't found that to be the experience. How would I get funding for programs such as this? I mean, that's kind of a wide open, but I think they've all talked about the availability of funding. Those for rural areas, I want to tell you, and one of my pledges through what I do at GEMS is the new Siren Act that was approved through the Farm Act bill. It's kind of an obscure little notice that there's a couple of $1 million in EMS funding that's going to be there for rural areas. So if you're in a rural area, start to build up all of your data about how rural your area is, because that money, and it is my pledge that we're not going to turn any of that stuff back in. We want to spend all of that money. It is a 75-25% match. So if you need an ambulance in a rural area, the government is going to have 75% funding for you. If you need AEDs, they're going to give you 75% of that. So another question here is about when you have a program that large, what was your experience with the manufacturers about getting a good deal on the AEDs?
Through the bid offer, we were able to negotiate. But most of them, the great thing is with the manufacturer of choice that we chose for the city of San Diego, in turn, and ended up bringing all the other AED manufacturers down in price.
Isn't that interesting?
Yes, when we initiated.
So you bulk purchase them and then you sell them to the various sites that want to put them
we don't
on?
actually sell them. They get their AEDs. What we're kind of like a one-stop shop for people who would like that. And also a smorgasbord. So some people like to buy their own AEDs. AEDs come directly through all the manufacturers. We don't get involved in that part. We just provide the program management services and the incident management services as well as the
But you give them
training.
a shopping list. They can shop wherever they want for that low price?
Yes, actually. Yeah, we do recommend that they look into what they what they pay for a high-end quality AED.
And only because I'm familiar with the university hospitals, they do the same thing. They represent all of those 180 ambulance services, and they do bulk purchasing, right?
Yes.
And you find the same thing.
Right. Drive the cost down for the end user.
Yes.
Yeah, pretty significant. Sir?
Hi, thank you. I'm Jim Resnick from Bethesda Chevy Chase Rescue Squad in Maryland here. First of all, kudos to the people that put this together because of the range of programs, the geographic range, and so on. I think it's very cool. This question actually is for Mo, but I think it's for all three groups. Critical incident stress debriefing certification and what you guys are doing post an arrest and dealing with the bystanders that did perform CPR, perhaps used an AED. But I could also, we could talk about that certainly in terms of an opioid situation, a bleed, anything like that. Where's the certification? How do you do it, et cetera? Thank you.
There's an international organization that provides that training, and you can find them anywhere throughout the states. I'd be happy offline to share more of that information with you, where you can find them. A lot of times your churches provide that. We have a large Christian church in San Diego, the Rock Church, which actually comes. They provide that training for free for first responders and other community members who are interested in obtaining that training. And it is training from the international organization that provides, the steps of what to do. Very, very beneficial for people.
Do you find that it catches on with the restaurants in San Diego, that if one has an AED, others want to get involved?
Restaurants haven't been so much, but we do have some restaurants. In fact, the Cone family, who are well known in San Diego, have implemented AEDs into some of their locations. George's by the Cove. Some high-end restaurants are starting to implement AEDs into their program.
I'll just tell you that I have a restaurant in my area where we've put a box up that says, on the way out, if you'd like to donate, we're going to raise money to have an automatic defibrillator for you here. And people throw $5 in there. So it's one way that I really recommend that you look at that. Another question really is about people that are afraid when they're on the phone to do CPR because they're going to crack the ribs or whatever. Do you ever address that? Do you have the dispatchers address that?
It's all about technique. It's all about technique and using that heel of your hand to press on the puck that sits over your heart, which is that sternum bone, the breastbone. And again, if you can get an audience in front of people and give them hands-on, they really get that.
Somebody's quoting a GEMS article where it talked about faster rates increasing survivability. So wouldn't it be better to bring them up to the 120 range, 2 per second at 120? What do you teach? Do you sing to them?
I do sing. I sing and I dance in my classes. I have a lot of fun. I have theatrics in my background. So I do teach 100 to 120, but what I really focus on with them is at least 100. Again, less is more. The less that they have to remember, just like the inches. Who brings a ruler with them to cardiac arrest? I mean, keep it simple. 1/3 for everyone, and you're apt to get that good compression depth in.
And we just pushed out the gentleman in this country that had seen a while ago the parody of CPR on The Office. If you've never seen that, look at it on YouTube. I'm sure you're laughing. But actually, he remembered them clowning around but saying that they had to do it to stay alive, and he saved a life with it. So there is beauty in that whole poetry thing. Somebody up here have a question, comment? No? Sir. Ma'am.
It's cool. My
You're
name
way
is
back
Sam,
there.
Yeah, it's hard to tell. So my name is Sam Smith. I'm with Greenville County EMS as a paramedic. And my question is mostly for Mo and Dominic and Daniel. So when you started your programs, did you have an issue, like how did you staff the community outreach and the teaching the classes and reaching more people? And was it with field staff? Was it with a completely different team? And how did you get people to buy into that and volunteer for those types of programs?
Well,
go ahead.
Okay, well, we actually used fire personnel. Started out very small, and what happened because of the topic, it just started to grow like wildfire, and we ended up bringing more staff on. Our program actually is a self-sustained program underneath San Diego Fire Rescue, which is pretty amazing, and we designed it that way because of, budgets go up and down. But we utilized personnel to see how that would work. The way we structurally organized the program, we made it a self-sustained program, therefore supporting staff salaries in getting out to reach out to the community. And again, those program advocates, people that have survived cardiac arrest and those who have lost loved ones to cardiac arrest, are great resources to get out there and spread this message as a team. They're a strong part of our team as well, and they volunteer.
We have a program called UH Kool-Aid, so drinking the Kool-Aid. And everybody jokes, but I made Kool-Aid and little packets we passed out. But it really, we started small with a couple of schools, and it morphed a lot faster than what we really thought it was going to. We had a superintendent that did us a favor, and he sent it out to all of his colleagues, which sent it out to the next group. But tell a friend, tell a superintendent, I guess. But anyways, we're very fortunate. We have a fairly large staff. We have a staff of about 100 instructors that we also do event medicine. So we have quite a bit of bandwidth, but we also have engaged all of the providers. We don't want to go into a school, into a community without having fire and EMS along with and police with us, because one, it expands the reach, and it's a true partnership. Our institute, we believe in the building life-saving communities, and that's building life-saving communities within the community, and you need everybody involved. So the hospital, we use that for all of our accreditations. However, we support the communities, and we want the fire chiefs, we want the providers with us in all of this we do, and that's actually how we're able to expand. We can actually do 3 school systems in one day, and train. We can train 300 to 600 people in a day.
I think the other thing that helped too is it's very easy to become a Stop the Bleed instructor. You just go to the website, and if you're basic EMT on up, it's all basic care. Nobody needed anything. There wasn't a big involved 5-hour class to become an instructor.
Right.
2 of our last quick questions is how many tourniquets per bucket, and how many wound dressing per bucket?
So there's one tourniquet, there's one bleeding control kit in there, and that has a Coban and tourniquets and quick clot, combat gauze. But then we also have ACE wraps, we have 5x9s, abdominal pads, 4x4s, and so you can probably handle about 6 injured people.
And you find one tourniquet's enough? Haven't used it yet.
Haven't used it yet. Yeah. Thank God.
Yeah. So some people would say that they want to put a couple more tourniquets in there. That's up to your own program. And again, through bulk pricing, you'd be surprised how you can get the price of those tourniquets down. We pay about $8 a tourniquet now. $8 a tourniquet.
Yeah, so it's not a cat tourniquet, but they're only going to be used once.
So ask them on the exhibit hall floor if they'll match that $8 a tourniquet for your program. Also, on the hands-free courses, the AHA has strict regulations on instructor-to-student ratios. So are you just offering a demo-style course, Maureen, or if so, what type of liability is that placed on the instructor or organization?
I don't see any liability. I'm just educating society on simple hands-only CPR, on simple recognition and response. Most people in society don't take certification classes, so I see no liability with it.
Okay, great. I want to thank you very much. We're going to conclude. This has been a great webcast. Let's hear it for our audience. Stay tuned on GEMS.com, because I'm going to find out how we're going to spend all that siren money. I'm going to make it a simple way for you to click through and get some money. Thank you all.